Hey everyone, and thank you for joining the webinar tonight. We'll be presenting today about KYZATREX, oral testosterone undecanoate. And the title of tonight's presentation is Should Oral Testosterone Be Your First-Line Therapy? My name is Dr. Andrew Sun. I'm a fellowship-trained men's health urologist. Currently, I direct the Center for Men's Health at Urology Partners of North Texas, which is our big urology group in the DFW area. And standard disclosure that I am a paid consultant for Marius Pharmaceuticals, who manufactures the product that we'll be talking about today. So KYZATREX, we'll start with the indications and box warnings. KYZATREX is oral testosterone undecanoate, and it's indicated for testosterone replacement in men with either a deficiency or an absence of testosterone, either because of primary hypogonadism or hypogonadotrophic hypogonadism. The main sort of safety things to consider, the main one is the elevated blood pressure, and we'll talk more in detail about other sort of safety events such as polycythemia and their relative risk factors, but blood pressure is the main one to consider. On the contraindication side, KYZATREX is contraindicated in patients with breast cancer or a known or suspected history of prostate cancer, as well as women who are pregnant. It is not indicated for women, period, but specifically the contraindication remarks about women who are pregnant. And like I said, the warnings and precautions here, polycythemia, things like that, we'll get into more detail later on. And as you'll see in the very middle line here, the most common adverse reaction for KYZATREX with a greater than 2% incidence in the clinical trial was just hypertension. Everything else was below 2% in the studies. All right, so to start with the talk, everybody sort of knows that there's a huge need for testosterone replacement therapy. We think that low T affects at least 20 million men, if not more, between the ages of 20 to 65 in the US. And over time, that number appears to be growing, probably in concert with the fact that overall general health has been declining, obesity is rising, and these kinds of things. Based on the ADAM questionnaire, which is a standardized questionnaire for the symptoms of hypogonadism, you can see that so many, it's very, very common for men, just any old random men that filled out this questionnaire on the website, to have many of the symptoms potentially associated with low testosterone. Probably the most common symptoms that I treat are things like fatigue and low sexual desire, but certainly also erectile dysfunction and general sort of enjoyment of life, the ability to think and process, information quickly. A lot of this can be related to low testosterone. Testosterone therapy, of course, has a long history and has been through many different iterations. This is not a complete encapsulation of every version of testosterone therapy that has ever been created, but gives you a general idea of sort of what has been before. So the first testosterone that was synthesized was in 1935. This was an oral testosterone, but it was methylated in order to get it to absorb well. Now, methyl testosterone basically has a lot of liver problems. And so for a long time, we didn't have an oral testosterone option. So what do we have instead? We basically had injections, which came about in the 70s, still probably the most commonly used form of testosterone overall. Later on, 1995, 2000s, a lot of topical products. This comes in the form of gels and creams and patches and a variety of different topical administration methods. In 2014, there was a nasal testosterone that came about. That was a 3 times a day intranasal testosterone gel. There are EpiPen style, auto injectors for testosterone. And then in 2019, the first FDA approved oral testosterone undecanoate came about. Now there are 3, Jatenzo, Tlando, and KYZATREX, which will be the focus of tonight's discussion. Oral testosterone undecanoate is a completely different molecule than methyl testosterone. And so I don't want you to confuse the two when you think about the idea of oral testosterone, because oral methyl T and oral testosterone undecanoate, or we'll call it TU, are very, very different in how they absorb and their safety profiles as well. So some of the benefits potentially of oral testosterone therapy are that it's neat, it's painless, and it's very discreet. It is certainly easy to take a pill. It's invisible. There are no messes with this. It is not painful, and you have a variety of different dosing options with KYZATREX, specifically in terms of being able to adjust the dose to suit whatever your patient needs. Now, when you ask physicians in a survey, 41% of physicians agree that patients very often complain about injectable testosterone. And certainly, I'm sure the patient number is higher than that. So when oral testosterone therapies are now available, why are we still relying on injectable treatments? There's probably a lot of reasons for this. If we look at other disease processes, such as rheumatoid arthritis or type 2 diabetes, multiple studies have basically found that many patients would prefer to take a pill version over an injectable. And you can see the data here: rheumatoid arthritis, 79%, 76% for diabetes would prefer an oral medication taken daily as opposed to whatever other options exist. And translating that thought process over into the testosterone therapy world is why the topic of tonight's question. So the question for tonight's topic is, should oral testosterone be your first line option for therapy? So what is unique about KYZATREX or testosterone undecanoate? It's that unlike methyl testosterone, this is absorbed through the lymphatic system, which means it bypasses the portal circulation and therefore does not enter the liver to cause liver toxicity. The way this is taken is twice a day with food, because you do have to take it with food to get absorption through the lymphatic membranes. And in the clinical study for KYZATREX, 96% of patients achieved normalized testosterone levels at day 90. Whether or not they required titration, 96% of patients got there by the end of the study. At day 90, also, the mean free testosterone level increased 2x, and the SHBG levels decreased by 30%. Now, that is a unique property seen with testosterone undecanoate oral, which is that it actually lowers the rate of SHBG production. Less SHBG means a higher amount of free testosterone that is available for use relative to whatever the total testosterone number is. And the schematic here on the right is basically showing how the prodrug molecule essentially gets absorbed directly into the lymphatics, bypasses the systemic circulation, and therefore does not, bypasses the liver, basically. So the unique formulation of KYZATREX is a self-emulsifying drug delivery system, which incorporates something called phytosterol esters. KYZATREX is a soft gelatin capsule containing either 100, 150, or 200 milligrams of oral TU in a formulation with the other components that are here, including the phytosterol esters. The pharmacokinetics of oral testosterone are shown here. Now, this in the FDA trial, you give a dose 12 hours apart with a goal of achieving a C average over a 24-hour period. And so here, as you can see, the doses were given at hour 0 and hour 12. Because these medications have to be taken with food, of course, that may not be exactly the times at which the patient takes it, because it depends on when they eat, but essentially 1 dose in the AM and 1 dose in the PM. What you can see here, based on these pharmacokinetic curves, are that the peak testosterone level is achieved about roughly 4 hours after administration, with the general area being between 3 and 5 hours after administration, which is why we recommend, or KYZATREX recommends, testing patients' blood levels 3 to 5 hours after the administration of a dose. And here you can see some plasma and serum levels on the right. You can see that the Cmax gets almost up to 1,000 at about 970 on the serum, with a C average of 451. Now, these are all patients in the clinical trial. All patients in the trial started at a dose of 200 milligrams twice a day and were titrated up or down, but mostly up, as needed to achieve therapeutic testosterone levels. The safety profile of KYZATREX is very favorable. The only adverse effect that was noted in greater than 2% of patients was hypertension, coming in at 2.6%, and this is after 6 months. A very common side effect of testosterone replacement therapy in general is polycythemia or erythrocytosis, meaning an increase in your red blood cell count. Officially, with KYZATREX, this did not cross the 2% threshold, but was seen in 1.9% of patients where their hemoglobin went up. If you look at the sort of bottom, more delineated data, the increase in systolic blood pressure was about 1.7 millimeters of mercury, and was only seen in patients with pre-existing hypertension or diabetes. There were no drug-related serious adverse events in the trials, and the hemoglobin increased by about 0.5 and plateaued after 90 days. No patients in the trial discontinued due to erythrocytosis/polycythemia as well. This is other data from the pivotal KYZATREX clinical trial. On the left side, in the top left, you'll see the free testosterone, which significantly increases pre and post treatment. And it increases actually at a higher ratio than the total testosterone increases, because the sex hormone binding globulin is being suppressed by the medication. So in the bottom left here, you can see how the SHBG levels have gone down at day 90 and even down a little bit more out to day 180. And so that's a very unique property of oral TU. On the right side, we have the pituitary gonadotropins, FSH, which stimulates sperm production, and LH, which is normally responsible for endogenous testosterone production. You can see here that on day 90 and day 180, although their FSH and LH levels have gone down on therapy, they generally are still preserved in the normal range, which is above about 1.2. On average, these FSH and LH levels are not going all the way to zero, which may have implications on secondary side effects that are often seen with testosterone therapy in regards to completely suppressed FSH and LH levels. So that's a very unique aspect of oral testosterone here, KYZATREX, in that it does not seem to completely suppress endogenous LH and FSH production, although it should be noted that it is still going down. So these are some other blood parameters that were noted on the clinical trial at the end of the study. You can see that PSA went up a little bit, 0.15 nanograms per milliliter. The hemoglobin, as we discussed previously, went up about 0.5. And you look at the bottom three, cholesterol, triglycerides, and fasting insulin levels all actually declined while taking KYZATREX in the patient population. In terms of clinical outcomes, in the KYZATREX patients, when they studied them at the end of the trials, they basically uniformly and broadly reported an improvement in most of the symptoms that are commonly associated with testosterone deficiency. So these are on different types of validated questionnaires, but essentially when it comes to mood, sexual activity, sexual desire, erectile function, fatigue, most all of these things have improved on testosterone therapy, as you would expect them to. So then, a few economic and practical considerations. One thing that's unique about KYZATREX that differentiates it from other products is that it has a cash-only model exclusively, and therefore there are, generally speaking, no need for doing prior authorizations because this is a cash model with less time spent, arguing with insurance and that kind of process. That tends to simplify the process for both the patients and the providers. Because of that, there's also cost predictability. And in general, it's a very convenient option for patients as well to be able to take a pill by mouth at home. Just a few other notes here in terms of managing patient expectations. Oftentimes when you treat patients with KYZATREX, sometimes the levels are not quite as high as you may expect them to be. Many forms of testosterone can cause a lot of peak to trough variation. KYZATREX has a relatively smooth peak to trough kind of ratio. And so, it kind of maintains people in that sort of nice middle ground. The other thing is that although you are increasing total testosterone, you are also lowering sex hormone binding globulin, which has the effect of raising free testosterone. So only when you check the free testosterone and SHBG levels can you see this effect, but they may actually be getting an outsized increase in free testosterone that you're not measuring if you only measure total testosterone. So that is something to keep in mind as well. So in terms of guiding patients who are transitioning from other forms of testosterone therapy, you just kind of explain the differences between the different medications, and that, I'll leave up to each of you individually to kind of go through. But the idea here is that it is a general way of doing testosterone replacement therapy that perhaps is smoother on a daily curve standpoint. New testosterone patients should wait at least 7 days before checking their labs, and the labs should be checked between 3 to 5 hours post administration of a dose, which must be with food, which therefore implicitly means that these are not fasting labs. These are labs with KYZATREX with food 3 to 5 hours after taking the dose. And then the most common side effect, as it says before, is basically an increase in blood pressure, which occurred in 2.6% of patients. But things like that should still be monitored throughout the course of treatment. All right, so that does it for the prepared remarks. Thank you for your attention tonight, and then we'll open it up for questions.